I have never been petite. I remember when I was around 6 or 7, my mom taking me jean shopping and breaking the news to me gently that I would need to wear the husky jeans. I didn't know what husky jeans meant, but by the look on my mom's face, it told me it wasn't good. I was picked on both in school by other students and at home by my brothers. I remember dieting as early as 9 years old. I tried eating Snackwell cookies instead of Oreos. I began working out when I was around 9 or 10 with the Get in Shape Girl tapes. And when I was in high school, I moved on to the Cindy Crawford VHS workouts. Our kitchen cabinets were full of everything low fat. And my mom was constantly on a diet, always trying to get smaller, always. So it should come as no surprise that by the time I got to high school, I had a full-on eating disorder. That's right, I was bulimic and was from high school all the way into my 30s. How could I have avoided it? With the supermodel craze in the 90s and heroin chic at its pinnacle of fashion, being skinny was pretty much all I could think about. Thankfully, with a lot of help from therapists and some soul-searching and some gut-wrenching work, I am no longer bulimic. However, my doctors do call me overweight, and I wonder why it matters. If my numbers like cholesterol and blood pressure are good, why does it matter if I have a little extra weight? And who's setting these standards anyway? If there's one thing I've learned by doing this podcast is that every person's body is very different. How can there be such blanket statements about weight when there is such variation in people? And don't even get me started on the drugs. Clearly, this is a fraught topic for me, and I have a ton of questions. So buckle up, y'all. Let's get into it. I'm with Dr. Tiffany Lowe Clayton, who is I've never heard this before, a bariatrician. It kind of sounds like a politician, but a little different. What is a bariatrician?
Yes. Well, bariatrician is a weight loss specialist. We actually focus on helping patients not just lose weight, but successfully keep weight off.
So this is a fraught topic for me.
Yes.
And it's a fraught topic for a lot of people, because society, especially the American society, values a youthful body so much. And I'll just be perfectly honest with you. I used to have an eating disorder. So this is something that I've battled with, this whole body thing. So I have so many questions about weight loss and all that comes with it. You're a doctor. And do you hear your patients, especially the patients that are in larger bodies, come in talking about the bias that they basically feel is against them the minute they walk into a doctor's office?
Oh, absolutely. First things first, when we think about obesity, really it's a pandemic because it's worldwide, but especially in this country, we know that it's increasing and it's growing. And as a matter of fact, it's estimated that by 2030, over half of the American population will have had a diagnosis of obesity. So when you say that you have had issues or struggles with your weight, you are not alone. There are so many people who deal with that. But because there is still a stigma of health and what a healthy body should look like, when a person struggles with obesity, there's also a whole lot of bias that goes along with it, that people may be eating too much, or they may be lazy or not exercising. And it just really reinforces a lot of the discrimination that can happen with people who struggle with their weight and really can impact them emotionally, mentally, physically, all of the above. So it's really an issue that we need to address.
Well, yeah, because from what I've understood, and I've done a lot of reading on this, it's kind of my passion, that a lot of people who are in larger bodies, and I'm talking like much larger bodies, go to the doctor and they won't even address their problems until they lose weight, like it be a heart problem or a hip problem. And so do you think that skewed the data on such diseases because these people aren't going until they absolutely have to, therefore making it look like weight is causing a much bigger issue than it actually is?
Well, the thing is that when a person is at an unhealthy weight, it can increase the risk for medical conditions. As a matter of fact, we know that there's over 200 medical conditions that are associated with obesity.
Like what?
Oh my goodness. Diabetes,
like the big ones, yeah.
Diabetes, heart disease, to your point, arthritis, you can think about things like sleep and sleep apnea, but then also psychological issues like depression, anxiety. Yeah. There's just so many disease states that have obesity as a major underlying factor. With that being said, what we also see is that there is a discrepancy in seeing obesity as a chronic disease state, just as we would treat somebody for high blood pressure, diabetes. It's really important to look at obesity as a chronic disease. Most people who struggle with their weight don't want to have a struggle. They have issues that can, really impact their weight, whether it's where they live, what we call social determinants of health. Genetics plays a major role.
Oh, yeah.
Right. If you have one parent who's overweight, it increases your risk for obesity by 50%. If you have two parents that's overweight, it increases your risk by 72%. So looking at all of the things that go into why a person struggles with their weight, not just what they eat or how much they exercise, which are important, but it's important to look at all of that. And what we find is that when individuals go to their providers, their healthcare providers, the conversation isn't happening enough.
Right.
It's not happening. And obesity in and of itself is underdiagnosed, which really can then lend to that stigma that we talked about as obesity not being a chronic disease.
I find that shocking that you think that people are not being told they're obese, because I've been told I'm obese. And I'm a size 14, 12, 14, depending on the week.
Yeah.
And I don't consider myself an obese person. I regularly exercise. I eat very healthy. I drink very moderately, and yet I'm obese.
Yeah, by the standards, right? By the standards, when we think about like the body mass index, which is what a lot of people use, as a standard for obesity. And I'm not a big fan of using.
Okay, I was going to ask you because I'm like, girl, I've done my research.
Yes. I am not a big fan of using body mass index by itself to measure a person's having obesity and or having risks for medical conditions related to that. There's so many different ways we can measure it, but it's still something that we can easily assess and that we can easily use. And so when somebody has obesity or struggles with their weight, it really is important that the doctor really looks at it. I'm an osteopathic physician.
What does that mean?
I really focus on preventive medicine. I believe that an ounce of prevention is worth a pound of cure.
Oh, yeah.
And so when I told you that there's over 200 medical conditions that are associated with obesity, well, guess what? Treat the obesity. If we treat the obesity, then we can not only improve, but we can even reverse some of those medical conditions that a person has.
Yeah.
So I say when a person struggles with their weight, don't avoid having a conversation. Let's talk about it. But talk about it in a way that's compassionate and that's respectful of that person's struggle, because that person truly is struggling and wants help for that.
Well, there's a lot to unpack there, but let's start with the BMI.
Okay.
Talk to me about the BMI.
Oh, absolutely. Well, first things first, BMI was not even originally associated with obesity per se. It was over, I don't know, 100 years ago or something like that, that a mathematician started to use BMI, and it was on short-statured white men.
That's right. And it was meant for insurance.
And it was meant for insurance. Originally, it was actually used to calculate a person's age based on their height. But again, all of the people that they were calculating it on.
Short white men.
Short white men, not women, not people of different ethnicities.
Exactly. I'm like, how on earth can you look at that number and equate it to you and I?
Right, exactly. So what ultimately happened was that it did start to become associated with insurance, and then eventually became associated with obesity by looking at a person's height and comparing that with their weight. And we know that a person who has a body mass index of greater than 27 is considered to have obesity, or greater than 25 is considered to have obesity. And a person who has a body mass index of greater than 30 is a person who has obesity. Or I said that wrong.
Overweight.
A person overweight and obesity.
Overweight and obesity.
Yes.
Yes.
And so it's easy. Many insurance companies still use it, but it's a terrible measure, because what it doesn't account for is a person's what we call fat around the belly, their visceral fat.
Yeah.
Nor does it account for the risk that a person may have to develop diseases. So in different ethnicities, we actually see that they may be at increased risk at a lower body mass index than what the traditional 27 or 30 body mass index is.
And what is telling you that they're at a risk?
Well, it's the amount of body fat that a person may have in comparison to the amount of muscle.
Okay.
We can
how do you
also
measure for that?
Well, there's better ways. There's better ways to look at it. So I would say, yes, use the body mass index, but just use it as a piece of the puzzle. Also, look at waist circumference. Your waist actually tells a lot of information in terms of the risk that a person may have for cardiac diseases or other cardiac and metabolic disease states. So if in women, our waist circumference should be less than 35 inches, and in men, it should be less than 40 inches. So that's actually a measure that you should use in addition to the body mass index. Also, when you look at a person's waist to hip ratio or their waist to their height ratio, all of those things give better indicators of risk for disease states, as well as a body's composition, because you may be 200 pounds, but you're not composed of 200 pounds of fat.
Exactly.
There's muscle there. There's
bones and
there.
water.
Water there. Absolutely.
Sweaters in the winter.
Exactly. Well, sweaters in the winter,
Yeah,
right?
yeah.
Shoes and pants and all that stuff.
Yeah, I want to get naked when I go to the doctor, but they never let me.
So we have to teach patients and providers alike to take it all into account.
Yeah. So what have you ever heard of healthy at any size? This movement, it's a new movement, and like that just says the size of your body doesn't necessarily indicate your measure of health.
Yes.
And what are your thoughts on that?
So I have heard of it loosely. I haven't delved into it a lot, but it actually lends itself to have a lot of truth to it. So you're absolutely right. The size of your body may not always indicate a measure for health. In what we just talked about, looking at your body composition is very important, because we can see some people who may be athletes who by body mass index alone could be considered to have obesity. But what if they're full of muscle?
Yeah. And how are you measuring? Because you did say fat percentage versus muscle percentage. How are you measuring that? How do you know?
Well, we have a machine in our office.
Okay.
When patients come to see me, I put them on that machine, and it helps me to understand their body composition.
Okay.
But many of the high grade scales actually can do that for you now. So, and those are ones you can get right over the counter at a store.
How do they know? It's so crazy.
Science
You're like,
and the technology. Now that's not my
like
strong suit.
Real smart people that do like
Yes.
screws and wires.
Yes, and works with a whole bunch of numbers.
Yeah.
Yeah, but they can, and they really do give you a lot of good information.
It's accurate? You think these scales
It's fairly accurate. Yes, it is. It's fairly accurate. But I will also say that if you have a concern or a question, then follow that up with going to see someone like myself who can give you more information and guided information.
Okay.
That's based in science and that's really accurate information.
Okay. So let's say you have a person who comes in and is from a big family. Mm-hmm. You know, their mom is big, their dad is big. They and their numbers are good. They have good cholesterol. Their heart rate is at a good rate. Everything. They don't have diabetes. They don't show numbers for pre-diabetes. But yet, when they get their fat measured,
yes,
they come up as overweight or obese. Mm-hmm. What do you say to that person?
So when we think about a person like that, that's a metabolically healthy person who has obesity. So that's what that individual is. And their body composition may play itself to that. So when we think about genetics and how genetics plays a role, we know that when a person is in an obesity promoting environment, they're going to respond differently based in large part on genetics.
So when you say an obesity promoting environment, you mean they have a lot of processed foods at their house. The sedentary lifestyle is something that's taught, that kind of thing.
They may be in a food desert or even worse, a food swamp.
100%, yes.
And so you can have two different individuals with two different genetic profiles, and one person's going to respond differently than another person will. There's one person who's more susceptible who will eat those types of foods or be in that environment and really have a struggle with their weight. Mm-hmm. Others will not. And so when we look at that and we really start to understand how genetics plays a role or how people respond to that, we know that people who are metabolically healthy, who have obesity, are also genetically predisposed not to necessarily have health issues, at least wise early on. Ultimately, it may impact them in terms of their bone structure, arthritis, and those types of things. But getting individuals to a healthy weight, to one where they can not just look good, but they also show that they're well, is going to still be really important. So I still say an ounce of prevention is worth a pound of cure. Just don't use the body mass index alone as the measure of success.
So like you said, it may affect them when they get older. Is there data to support that? Like someone who is metabolically obese, is there data that shows as this group of people go through life that at the end of it, they've been getting these types of diseases?
Yes. And if we look at the data, especially when I talked about that waist circumference, especially when we're talking about visceral adiposity,
which is the belly fat.
Is the belly fat, yes. When we talk about individuals who have that, yes, there is certainly data that shows that increases the risk for what we call cardio and metabolic disease states, like high blood pressure, diabetes, insulin resistance, if they still have that long term.
Okay. Well, I want to move on back. I'm going to move on and backwards, back to the bias at the doctors.
Yes.
Because I know a lot of people who are in pain because they have a larger body. My mother was one of them. I have friends who have this problem, and their skeletons can't support the weight.
Right.
And so their knees are starting to go yada, yada, yada. But yet they can't get help until they lose weight. Why does it matter that their body is big before you fix the knees to make them more active? You know, like why is that part of the equation? Like to be denied surgery until you've lost a certain amount of weight? Because what's frustrating for these women and men is that diets don't work. It's so hard to lose weight.
Oh my gosh, yeah.
And so they're frustrated. Like, I want to lose weight. I can't work out because I'm in pain. Like, what, you know, it's like this vicious cycle they're stuck in. So why is weight and the denial of surgery given to those? How does weight play into anesthesia and all that?
Well, first of all, I think it's a loaded question, but I think it's an excellent question because more times than not, when you have a person like an orthopedic surgeon who has to perform surgery, they do require you to have a certain body mass index. The biggest reason for that is because when we think about the surgery in and of itself and the risk for complications with surgery, we know that when a person is at an unhealthy weight, it can ultimately increase the risk for complications
like
with
what?
The surgery. Infection. Sleep and sleep apnea. If there's underlying sleep apnea that's there, they may have risk for anesthesia, healing and those types of things. So they will want you to get to a healthier weight to have a safer surgery. But then also the actual procedure itself, if we want it to sustain long term, then if a person is at a healthier weight, then the actual procedure can last longer. So if a person has a knee replacement or if they have a hip replacement, it actually lasts for a longer period of time when they're at a healthier weight.
Right.
And if a person goes through a life-changing procedure such as that, and they don't necessarily, and we know that oftentimes weight can be a contributing factor to the issues that they're having.
Sure.
If they don't learn the principles to stay at a healthy weight or to get there, first of all, and then to stay at a healthy weight, then you're going to have recidivism, or you're going to have, again, issues as it relates to that. So
what does recidivism mean?
It's going to just come right back.
I see. Okay.
Yeah, the weight will just come right back, and then the issue will come right back, and then you're having to go through another surgery again.
Yeah.
So again, with preventive measures and what we talked about, and for safety of the patient, many providers will ask that you have your weight at a certain level. Now, here's the caveat to that.
Got it.
The caveat is that if a person has tried and has struggled to lose weight and they haven't been able to,
that's my next question.
That's when they know they need help. They need a professional, someone who is trained, someone who can assist them to not just help them with an eating plan. I don't say diets because I believe the diets are temporary and they don't work.
Yeah.
But to come up with an eating plan that's good for a person's lifestyle, and then a fitness plan to help them stay physically active in whatever they're able to tolerate. And then also, when necessary, using anti-obesity medicine to kind of help that. So it's all of it. It's not just eating. It's not just physical activity. It's not even just the medicine. It's not just the shot that people like to talk about.
Yeah.
It's all of it. It has to be a comprehensive plan to work and to stay sustainable.
Well, I read that you're talking about Ozempic, right? Or a semaglutide.
Semaglutide, the brand names of it are Wegovy, and the other one is tirzepatide, which the brand name of it is Zepbound. Those are the ones that are actually indicated for weight loss specifically.
Gotcha.
The others are more indicated for diabetes,
right.
But we know that they can also help patients lose weight.
Right. I read that that medicine doesn't necessarily give weight loss to everyone. It's not a foolproof plan. Is that true?
Well, unfortunately, yes.
Yeah. So, and that's what's
there is no magic pill.
Exactly. Mm-hmm. So, if this is the part with diets that I just feel so badly, because it's incredibly difficult to lose weight. Mm-hmm. Incredibly. The amount of willpower, and not only just willpower, it's not as simple as calories in, calories out.
Right.
Because this is what I'm reading here, I welcome any kind of rebuttal you have to this. But calories in, calories out doesn't take into effect your metabolism will change as you lose weight and
my
right
goodness.
itself.
Yes, say it.
Yeah,
that's so true.
it's true.
So true. Well, here's the thing. It is more than calories in and calories out. And I'm going to say it for anybody who's listening who needs to know. It's not just about a person's willpower, nor is it a moral failure that a person has a struggle with their weight, right?
Can I get an amen?
Amen. Let's take it to church there.
Yes.
Listen, it's not about that, right? It's so much more than that. People who struggle with their weight don't want to struggle with their weight.
No.
It is something that they have been dealing with sometimes since they've been children. And they've gained weight and lost weight and have been stuck in this cycle of tug of war. There's so many reasons why a person struggles with their weight. We talked about genetics. Let's talk about some medications that patients may be on that actually may create a weight promoting environment. Or also, just like we talked about, where a person may live, what they may have around them. The biggest thing that we don't talk about, stress.
Oh, God.
And
Cortisol.
how stress, and that person staying in a state of chronic stress, whether they've dealt with adverse childhood experiences.
If they're living poor.
Yes. If they're living in a place where they can't do anything, or, all those things are chronic stressors where that person's cortisol levels, which we know can create weight gain, is always high. And so I've seen so many people who come into my office who have been very successful professionally, successful at doing many things, but this one struggle they still have, and they have to deal with that. So I 100% agree with you. It makes me really happy that you even say that no, this is not a moral failure.
No.
And it's not a lack of willpower, but it is something that we have to address mentally, spiritually, physically, and comprehensively to help patients really stay successful long-term.
Well, then how do we do that? Like, is every patient that walks into your office, is it 100% success rate?
So I have a pretty good success rate in my
I don't doubt it. I'm not trying to put you on but I'm just saying, given all these things, is it 100%?
So I really do think that it really is a lot to do with a person's mindset. And are they ready to make the change? No, it's not willpower.
Okay, how's it different?
It's mindset. Willpower's, to me, when a person says that they lack the willpower, that ensues weakness. But when a person says, I have to shift my mindset, so I don't have cheat days, I have choice days. Because if I chose to say yes, then tomorrow I can choose to say no. So that really ensues more power and empowering people to understand you already really have everything in you to lose it. You just need help and guidance to work with somebody who really is an advocate for you to be successful. So when I see patients in my clinic, and what I would recommend to anybody is go to somebody who understands the complexity of obesity and understands how to help a person get a eating plan that works for them, get an activity plan that works for them, see a behavioral health specialist if necessary, especially if there is an eating disorder that we're having to deal with with that patient, and then ultimately use anti-obesity medication in a responsible way for the patients that need it to help them be able to sustain weight loss.
That's a lot. You just said a lot right there. Yeah, the fact that it's an epidemic or a pandemic, in your words, is something I have trouble with too. Like the idea that, as someone who's been called obese, as someone who's been called overweight, like I look at you. Are you considered obese? Like, I feel like we're the same size.
Well, technically, by the scale, I am considered to have obesity. But I will say this, I'm very healthy and I'm very active.
I am too.
And you do have to take all of that into account, right? You really have to take all of that into account. And so that's why we're seeing the movements, especially in Hollywood, of the body positive movement and, really
neutrality and all of that.
Being happy with the skin that you're in. I'll say that there's a plus side to that in the fact that, yes, we want people to be comfortable with who they are and just really work to get towards a healthier version of that. But by the same token, we also know that body positivity doesn't necessarily equate when we talk about health risk and health parameters. So you got to take all of it into account and understand that, when you do struggle with an unhealthy weight, you do want to get someplace that is better. But, with that being said, it's more than just pounds on the scale. And it's more than just what we look like out here. It's also what's on the inside that counts. And you really just want a person to be happy with where they are.
Yeah.
Be healthy, be happy, and that ultimately will help a person sustain a quality of life.
What I think has been great about the body positivity movement is that we don't all have to look like supermodels. Yes. We don't all have to have flat stomachs. We, granted, you don't want whatever the name of that fancy fat is, but we don't want that either. But
the visceral fat.
The visceral fat, right? But I think, it's important for us to be represented in media. However, whenever you get to, like you said, the fail rate in diet is something like 97% whenever without help. It's extraordinarily high. Like even with Ozempic, I keep calling it Ozempic, but the weight loss injections that people are taking, when you stop taking them, the weight comes back for most people.
Well, let me tell you, that actually isn't a result of the medication itself. So I hear a lot of people say, "Oh, I don't want to take that because it doesn't work," and that's not true. Actually, thinking about obesity as a chronic disease, if someone's blood pressure is controlled, we don't necessarily take them off of their blood pressure medicine. We say, "Wow, it's controlled with the medicine." Same thing with obesity when we think about it as a chronic disease state. With that said, we have to understand that our bodies are miraculously made.
And that's very true.
They are designed to preserve even what it considers to be its normal point for weight, even if it's not technically normal on the body mass index scale or any other scale. So if a person has lived their life struggling with obesity and they lose a certain amount of weight, a significant amount of weight, it senses a trigger in your brain
that you're starving.
Right, exactly. That says something's not right here.
Yeah.
I'm losing weight, so I got to preserve. So what it does, because we're all controlled by hormones.
Yes, of course we are.
Is that it decreases your hunger hormone. It increases your hunger hormones and it decreases the hormones that make you full, and it can make a person crave and it can make a person eat. Also, when a person loses weight, their resting metabolic rate, or the amount of calories that it takes for a person to stay alive and rest, that actually decreases too. And if you have a decrease in your resting metabolic rate, a decrease in your muscle, and then you have these changes in your hunger hormones, what's going to happen? A person who loses weight is going to gain weight and can actually gain more weight than they've initially lost. So that's why I say it's more than just willpower or a moral failure. There's actually things that are going on with our brain and in our bodies that will fight our ability to lose weight. That's where anti-obesity medicine comes in.
Well, what scares me about, especially these injections, because I also have, I'm just going to tell you everything about me real quick.
Tell it all. Tell it all. I'm here.
That's what I do. I'm an open book. I have digestive issues. I have a very sensitive system. I'm a sensitive lady. And the idea of, from what I understand how these drugs work, is it slows down your digestive system and keeps the food in the belly longer so you don't get as hungry as often. And the idea of messing, for lack of a better word, messing with an entire system of a body just to lose weight seems very drastic to me and scary for someone like me who's already so sensitive. What's your answer to that?
Well, first I'm going to say that whenever there is no one size that fits all in medicine, nor is there one size that fits all when it comes to obesity medicine. So you do have to individualize the care. And there are some people, and when I said earlier, when you give these medications to people that it's appropriate for, you got to individualize your care. It's not meant for everyone.
Okay.
So I would say that it depends on what type of digestive issue a person has. If a person already has a risk for that stomach paralysis that you might hear a little bit about, gastroparesis, then you wouldn't give something like this to them. But in most individuals, they can really tolerate the medicine, even if they have other things like reflux or other constipation and those IBS and those types of things. And so I would say you have to go slow and go with what works for you, working with a person that's trained to be able to help you with that. So also, eating a healthy diet is going to be important. We can't get away from eating a healthy diet and staying away from foods that are triggers, that are known triggers.
Like what? What do you mean by that?
Well, fatty, with this particular class of medicine that we're talking about, fatty foods, greasy foods, those types of foods are actually triggering to this medication. Your body doesn't do well with it. Yeah, it can make you sick.
I see.
So if you're eating a healthier diet full of good sources of protein, healthy fats, fiber, that's really important, and then staying well hydrated, many people can get through some of those digestive issues that they deal with.
Okay. Let me ask you this also about some of these weight loss drugs. How long, and I'm going to keep going back because it's such a hot topic, the shots. From what I've heard and read, that it's only been studied, the length of time that the people have been on these drugs is roughly 2 years, is the longest study that's been done. And it makes me think back. I'm just going to go through the whole question. You can answer, obviously, any way you want. Like fen-phen. Fen-Phen came out back in like the 80s and 90s, and it caused, Fen-Phen was terrible. And a lot of people who were overweight were put on Fen-Phen, and it was terrifying. It was bad for people's hearts. People died from this. The longer they were on there, they found that. So can you speak to the length of the study, and if you're not worried about the results of a longer term dosage or being on this for a longer term? I hope I'm making sense. I feel like I'm rambling.
No, you are. You're making perfect sense.
Okay, cool.
Yeah.
If you've been on, let's say, Wegovy for 6 years, which is longer than the length of any study that's been done, I mean, we don't know what could happen at that point. So how do you feel so confident in giving this to someone that you said, if it's a chronic disease, they're going to have to be on it forever?
So I think it's a phenomenal question. And there's a lot of misconception about the semaglutide molecule in and of itself. So you're right in some regard, is that when we think about it in terms of obesity specific and the treatment of using the semaglutide molecule for obesity, the longest study to date at this point is about 2 years, although they're consistently doing studies.
Well, they have to consider it so well spread at this point.
Right. But the semaglutide molecule itself is not new.
Okay.
It's been around for years. We were just using it in diabetes.
I see.
For many years. And so we know that the semaglutide molecule has been in over 20,000 patients have been studied with this molecule for a long period of time, as it relates to diabetics first, and now just recently specifically for weight loss.
And how is it differing when you give it to a diabetic versus giving it to someone who's using it for obesity? How are you giving it? I'm assuming it's in dosage.
It is in dosages. Also, when we think about it for lowering blood sugar, it lowers a patient's blood sugar regardless, but it lowers the blood sugar to a certain amount, and then the weight loss can continue to move on. And so there's a ton of studies that are out there that really looks at the difference for using the semaglutide molecule in diabetic patients versus using it as it looks at specifically obesity as it comes out. So it won't necessarily, knowing that it lowers blood sugar, you don't necessarily want to give it to a patient if they're taking other medications that can lower blood sugar, like insulin, for instance.
Right.
You don't want to do that. And that's why it's important to work with somebody who knows what they're doing. But when we think about the molecule in and of itself, it's actually not new. It's been around for a long period of time. And again, it goes back to the mantra of thinking about this as a chronic disease state. I always tell my patients, you're not going to get over your issues with your weight. This is something you've been dealing with for a long time. You're not going to get over them. You're going to get control of them. And the goal is to keep control of them. Gotcha. And the medicine will help you to do that.
Okay. And I understand that there's been shortages. It's been all over the news. There's shortages of this medicine. And some people who are on it can't get it for weeks at a time. And then there's these compounding pharmacies. Tell you, girl, I read a lot about this.
You have.
I know.
You have.
Explain what a compounding pharmacy is. And what are the risks of getting a compounded version of these weight loss drugs?
Yeah. So compounding pharmacies, and there are many reputable ones that are out there. I'll say that first right off the bat. But compounding pharmacies will at times compound different molecules together.
Which means make.
It makes them. And it's not just with these weight loss drugs, but with different types of medications. And they can be very, very effective if you go to the right one. But when it comes to this particular drug specifically, first things first, neither one of the companies that are making the drugs that are approved for weight loss have a generic version that's available.
That's what I've heard. You got to pay top dollar.
Yes. So, when we talk about the generic version of it, we don't know where the generic version is coming from. There really has not been any studies that really look at the safety or the efficacy of this generic / compounded, and we don't know what it's being compounded with.
Right.
So I really can attest to the safety of taking a compounded version of a medicine for weight loss. And as a matter of fact, I don't even give it to my patients because if I don't see it in research and I don't see it in evidence, then I'm not going to take a chance with a patient's life.
And those are the weight loss drugs that you see online for like $99. You can get like 10 shots of Wegovy-ish, whatever they want to call it, for $99 when really you don't know what you're getting.
You have no idea what you're getting. It's like some proprietary blend of who knows what.
Yeah.
And you don't know what you're getting. And people are really taking a chance.
Yeah.
Although it does speak to how desperate individuals are to get to a healthier weight.
Which feeds back into, for some people who are quote unquote morbidly obese, and it does affect their health. I can see the desperation there. But for some, it's straight up for their physicality.
Yes.
And do you address that as a weight loss physician?
I do. And again, it's individualized care, because we can see people who may have had bariatric surgery who might look great to everybody else, but we know that because they've had bariatric surgery and they're beginning to regain weight, or they're metabolically unhealthy, right? So their body mass index may say that they're not having obesity, but their numbers show that they're unhealthy and thin. That's another issue too.
Oh, yeah.
Then we have to address that. But yes, I definitely have a discussion with my patients. I talk to them. If they're not an appropriate candidate for these medicines, there are other medications that are available. If we can just focus with their diet and their lifestyle, or even in some people, just seeing a behavioral health specialist, dealing with anxiety, dealing with eating disorder like binge eating, or managing stress. Sometimes that will help a person be able to be successful.
There's so many factors.
Yes, it's so complex.
It is such a complex thing.
But I'm so excited, though, that we're having this conversation here and that people are talking about it more, because the more we talk about it and help people understand that, yes, this is complex and it is chronic, and we do have to have the conversation and do something about it, the more we can help people be healthy long term.
I could talk to you for 2 hours about this. Unfortunately, we don't have that on the schedule. So thank you for your time. And Thank you for being so open.
Absolutely. Anytime.
And hopefully I can have you back on, because I know I got another hour's worth of questions for you.
Anytime. Thank you so much for having me.
Absolutely.
It was a pleasure.
Oh, good. Woo, I had so many more questions to ask her, but we only had so much time in the studio, so we're definitely going to have her back. But listen, if you have any questions about what you heard about, any of the weight loss medications, heredity, I mean, at this point, I'm going to have to listen to it again myself to unpack what was all just said. Go to our website, wralfm.com/SarahHasQuestions, or you can find us on social at any of the WRAL-FM social media platforms. I want to thank Dr. Tiffany Lowe Clayton from WakeMed for her time today. And if you have any questions for Dr. Tiffany Lowe Clayton, you can find her at wakemed.org. Thanks so much for listening. See you next time.